Hi guys, I hope I am audible to all of you and live and clear. This is Dr. Patil, and in this video module, we are actually kickstarting a series of high yield revision for the upcoming FMGE exam. We will be doing 5 sessions. In 5 sessions, we will try to complete the extremely important topics from general medicine. That's the objective that we have. So let me tell you in very clear words that this is not an extensive review of medicine. We're not going into the depths. We're not going to build concepts in this series. The focus is on try to remember the key points that are helpful in scoring at least 50% marks in the upcoming FMG exam. So the target is to get 50% with the help of a little bit of logic, your understanding of pharmacology, pathology, and the biochemistry, physiology. You will be able to score another 20% more, and getting 70% from medicine is definitely good enough for us to sail our boat through the FMGE exam. Okay, so what is important from the rheumatology section, because the first session is on rheumatology, right? So I have shortlisted 6 important topics from rheumatology. Apart from the 6 topics that I have shortlisted, there are 2 more which I would know that you will be learning it from the other faculty, right? What are those? Yes, the first one is SLE. The second one, Antiphospholipid Syndrome or APLA, Antiphospholipid Antibody Syndrome. The third one is Scleroderma or the systemic sclerosis. The fourth one is Sjögren syndrome. Fifth one is Behçet syndrome, not a very detailed topic, but few key points. And then the last one is the immune-mediated inflammatory myopathies or immune muscle diseases or inflammatory muscle diseases like dermatomyositis, polymyositis. Okay. So what we will do is we will only focus on the extremely important high-yield topics. So when we talk about SLE, inside the rheumatology, that is the most important topic, right? So what is important from SLE? Most of the questions that we have come across in the recent times are about the antibodies that we see in SLE and its clinical correlations. That holds one MCQ for us, right? Then the second kind of MCQs that we have seen in the recent times is the most common manifestations of different organ involvement in SLE. Like what is the most common cardiovascular manifestation of SLE? What is the most common respiratory system manifestation of SLE? That is the MCQ template 2, right? MCQ template 3 is based on lupus nephritis, mainly the grade of lupus nephritis which you will study in pathology. I will focus on antibody and correlations, organ manifestations, and management of the SLE with focus on the newer drugs, because I anticipate that they will ask questions on that. Okay, so we'll start with SLE first. So when we talk about SLE, first thing is we should know some key points about the epidemiology. And typically speaking, SLE is a disease which is more common in second to third decade, and we all know that it typically affects females more than males with a ratio of 9:1. Inside rheumatology, we consider this ratio as the golden ratio, because there are several other disorders where we get this 9:1 ratio. For every 9 females diagnosed with SLE, there will be 1 male diagnosed with SLE. In simple words, I would say that SLE is a disease of females. Okay, there will be one more question asked through. When do you consider the patient with SLE as having late onset SLE or LOSLE, LOSLE, right? So when the onset of the SLE is after 50 years of age, ideal age of onset is second decade or third decade, but when it is after 50 years of age, then we will call it as late onset SLE. Okay, now coming to the risk factor. When it comes to risk factors, we will divide them into genetic factors and the environmental factors. Now when it comes to genetic factors, right, the strongest known genetic risk factors are related to complement deficiency, because patients with SLE are often found to have deficiency of some early complement components, and among them the most common component of complement system which is deficient in patients with SLE is the C2. C2 deficiency is the most common complement deficiency. This is an important MCQ point that I am giving you. This is the most common complement deficiency in patients with SLE. In patients with SLE. But what is the strongest genetic risk factor? It is the inherited deficiency of C1q. Inherited deficiency of C1q is the most potent risk factor, or in other words, strongest genetic risk factors. Strongest genetic risk factor or the most potent risk factor is the deficiency of C1q. The most common complement deficiency that we see in SLE patient is complement 2, right? Other than that, mutations in a gene called as TREX1 can also cause the SLE, and HLA correlation is particularly frequently asked MCQ point. Which HLA variants are associated with increased risk? It is HLA DR2 and DR3. Please make a note here. The HLA DR4 is protective. DR4 is protective. So if you have HLA DR4, please remember HLA DR4 protects you from developing SLE but increases your risk of developing what we call as rheumatoid arthritis, right? So DR4 is protective but it increases risk of rheumatoid arthritis. DR2, DR3 puts you at risk of developing SLE. DR4 reduces your risk of developing SLE but puts you at risk of developing rheumatoid arthritis. Okay. Now we just understood that SLE is a disease of females, more common in females than males. Obviously there must be reasons, right? And what is the difference between a male physiology and female physiology? Mostly it is related to hormones, right? So that's why there are factors from the environmental side which also have an influence on the risk of developing SLE, and the first most important risk factor I would talk about is the exposure to estrogen, right? In the form of oral contraceptive pills, right? Estrogen containing oral contraceptive pills increase the risk of developing SLE. And that explains, right, why it is more common in females, because hyperestrogenic trait is a risk factor. Whether you give it in supplementation or by gender you bring it, right, you have the risk factor. Another important MCQ they would ask you is which infection is implicated in the pathogenesis of SLE, and that is Epstein-Barr virus. Now whatever I am listing here, right, they are very, very important for us. Means you can follow the same factors, you can write the same factors in multiple rheumatological disorders and it will be still acceptable as an answer because they do play a role. Epstein-Barr virus infection is the most common infection implicated in the pathogenesis of SLE. Similarly, when it comes to rheumatoid arthritis, right, in case of rheumatoid arthritis, there is an infection affecting the gingiva, which is called as, the organism is called as Porphyromonas gingivalis, that has been implicated in the pathogenesis of rheumatoid arthritis. So there can be an MCQ asking you which infection is associated with increased risk of SLE. It is Epstein-Barr virus. Which infection is associated with increased risk of rheumatoid arthritis? Gingivitis, particularly caused by Porphyromonas gingivalis. Okay. Then consumption of tobacco in any form, whether it is in the form of smoking, chewing, sniffing, is associated with increased risk of SLE. Then exposure to silica. Please remember, silica, as we all know, is a immunoadjuvant. What is an immunoadjuvant? It is a substance which makes the antigen more potent. So the amount of inflammatory response or immune response and antigen triggers becomes more severe or more potent. So we use, for example, we use aluminium as an immunoadjuvant in vaccines because we are injecting small quantity of antigens and we want it to stimulate a very potent immune response, right? So to make them more potent, we combine aluminium with the vaccines, right? Similarly, silica is also an immunoadjuvant. So whenever there are some antigens against which antibodies are produced in the body, those antigens become more palatable to immune system and a stronger immune response can be elicited. That is why silica exposure is a risk factor for SLE, and not just the SLE but almost all rheumatological disorders. You might have come across this correlationship between silicosis and rheumatoid arthritis, right? It's very common. Then in the recent times we have increasingly recognized that vitamin D deficiency plays a crucial role in the pathogenesis of various autoimmune disorders, and the list is exhaustive. Means you talk about Sjögren syndrome, you talk about the SLE, rheumatoid arthritis, even multiple sclerosis. In all these cases, vitamin D deficiency is one of the risk factors, right? So this is an important MCQ zone from which usually every alternate exam we get one question, either related to epidemiology or risk factors. And here I want you to know that modest consumption of alcohol, modest alcohol means 2 drinks per week, is protective. 2 drinks per week is protective against the risk of developing SLE. Okay. So there are a few MCQ points that I would draw your attention before we go forward. The first point is which chromosomal abnormality is associated with increased risk of SLE. We just understood that females are at higher risk of developing SLE than males, and probably their hormonal milieu plays an important role. Now, what if I give someone extra X chromosome, right? So, if the pathology is related to female gender, what is the difference between a male and female at the genetic level? Females have two X's, right? Males have an X and a Y. So, basically, female has an extra X chromosome. Now, if there is one more extra X chromosome, what will happen? The risk of developing SLE increases. So, the most common chromosomal abnormality associated with SLE is Klinefelter syndrome, and the most common complement abnormality I have already discussed, that is C2 deficiency. The most strongest genetic risk factor is C1q deficiency, but most common complement deficiency is C2. Okay. Now, SLE being an Kunjarapatti, I understand. I mean, I'm in a stormy weather right now, so it might continue to disturb for some time. Okay. Now, SLE is an autoimmune disorder, as we know. So, when we say autoimmune disorder, either it will be a cell-mediated immune pathology or an antibody-mediated. Right? SLE is an antibody-mediated immune disorder, and that makes it type 3 hypersensitivity reaction. This is an important MCQ point. SLE is nothing but an autoimmune disorder which can be counted as a type 3 hypersensitivity reaction, which has been asked multiple times as an MCQ. Okay. And then another important MCQ from SLE that they will ask you is, what is the principal cytokine involved in the pathogenesis? Not just the SLE, for all rheumatological disorders, you should know the principal cytokine involved in their pathogenesis. Why we should know? Because when we go to the management of the disorders, we will probably target these cytokines which are involved in causing the tissue damage, right? So if I block the cytokine, tissue damage will be blocked. So the principal cytokine involved in the pathogenesis of SLE is interferon 1. Interferon 1, right? So for that matter, let us make a note. When it comes to rheumatoid arthritis, that is going to be TNF alpha. That is why when we treat rheumatoid arthritis, we treat them with anti-TNF alpha drugs, right? So when it comes to scleroderma, or what you call as systemic sclerosis, it is the transforming growth factor beta, TGF beta. Clear? So all the three are MCQ points. SLE, interferon 1. So if you have to treat SLE, you have to block interferon 1. Rheumatoid arthritis, TNF alpha. If you have to treat rheumatoid arthritis, block TNF alpha, right? Scleroderma, TGF beta. As of now, we don't have effective drugs to block TGF beta. Okay. So now coming to the most important part of SLE, that is the antibodies in SLE and their correlations. The first MCQ they will ask you is, what is the most sensitive antibody for the diagnosis of the SLE, right? The most sensitive. When you say most sensitive, it also means we are talking about the one which is most common. Most sensitive and most common literally mean the same thing here, right? And that is going to be ANA. Right? ANA is the most sensitive antibody in a patient with SLE, and thus it is also the most common antibody. Right? They will ask you two more questions. What is the method recommended for detection of ANA? Because there are several methods available, but for the standardization we have to follow a standard method. What is the method and what titer will be considered as positive? Right? So the recommended method is indirect immunofluorescence. Indirect immunofluorescence. This is again an important MCQ point. Indirect immunofluorescence. And the titer to be considered as positive is when it is more than 1 in 80. If you take a titer of 1 in 40, 5% of the general population will turn out to be positive for ANA. So to call it as genuinely positive, we need to have a titer of more than or equal to 1:80. Okay, the second MCQ with respect to antibodies they will ask is, what is the most specific antibody? The most specific antibody is anti-Smith antibody. Anti-Smith antibody is the most specific antibody. Okay. Now, the third MCQ they will ask you is, okay, ANA is most sensitive and anti-Smith is most specific, but what is the second most sensitive? And in terms of specificity, what is the second most specific? And the answer for both of these questions is same. The second most sensitive and the second most common and the second most specific antibody is going to be anti-double-stranded DNA antibody or anti-dsDNA antibody. And when we talk about the anti-dsDNA antibody, the first thing I would like you to know is that this is the most important antibody when it comes to a patient with SLE. because ANA is done only for the initial diagnosis. Once I have diagnosed someone as having SLE, right, after that ANA has no further value in his life. We don't look at the ANA titers, whether it is rising, whether it is decreasing, because it does not correlate with the disease behavior. But anti-dsDNA, it correlates with the disease behavior. So if the anti-dsDNA titer is going high, that means disease is becoming severe or it is getting flared up. If the anti-dsDNA titer is dropping, that means your disease is coming under control. So there are a few points to learn here. First thing is, it is Konjam Rashnath, I am in a very stormy weather. Here it is like raining heavily and literally like heavy winds outside. Despite the sound insulation, it's still interfering. I'll try to see what I can do for it. Okay. So the second most is done anti-dsDNA antibody, and with respect to anti-dsDNA antibody, first point is it correlates with disease severity. It correlates with disease severity, and whoever has anti-dsDNA antibody, right, they are at increased risk of lupus nephritis. So if you have anti-dsDNA antibody, your chance of getting kidney affected because of SLE is high. These are two very, very important, I would call them as golden MCQ points. Which of the following antibody correlates with disease severity and SLE, or which of the following antibody can be used to assess the prognosis in SLE, that is anti-dsDNA, right? Presence of which antibody correlates with increased risk of lupus nephritis? Anti-dsDNA. And in a clinically oriented SLE based question, if they say that okay, there's a patient with malar rash, fever, joint pain, and then now she has some urinary abnormalities and her anti-dsDNA titers are rising, it is pointing towards development of lupus nephritis. Okay. Now the next MCQ they will ask you is which antibody is associated with drug-induced SLE, and as we all know, it is going to be antihistone antibody. Antihistone antibody. So just to summarize again, the most common, most sensitive antibody is ANA. The method used is indirect immunofluorescence. To call it as positive, it should be more than 1:80. The most specific is anti-Smith. And the second most common, second most specific, that is anti-dsDNA antibody, which correlates with disease severity and the risk of lupus nephritis. And I forgot to mention the method of checking the anti-dsDNA. The recommended method is Criteria immunofluorescence. Criteria immunofluorescence. You need to remember these names because they are indeed important. Criteria immunofluorescence is the method that is recommended. So for the ANA, it is indirect immunofluorescence. For the anti-dsDNA, it is the criteria immunofluorescence. Antibody associated with drug-induced SLE is antihistone antibodies. In the recent times, this has become a template of asking MCQs, which of the following drugs are known to cause SLE. So I have made a small table of drugs which are known to cause SLE, which includes isoniazid, hydralazine, methyl-dopa, minocycline, quinidine, and propanamide. If you ask me, sir, which drugs I should remember particularly, which of these drugs are more commonly used in today's context? We regularly use isoniazid, right? We do use minocycline, especially dermatologists use it for acne, right? We do use quinine in pregnant female patients for treatment of malaria, and we do use propanamide frequently these days for as an antiarrhythmic, especially patients with WPW syndrome, right? And in OBG they do use methyl-dopa for treatment of pregnancy-induced hypertension, right? So these are the drugs that you need to remember for the drugs causing SLE. Okay. Now within these antibodies and SLE, another important MCQ is which antibody correlates with which clinical manifestation of SLE. So I have summarized it in a small table. So patients with SLE often have this antibody called as anti-Rho antibody, which is also called as anti-SSA antibody. Now you may be thinking, what is this SS, right? SS refers to Sjögren syndrome, which we will be discussing later, right? So Sjögren syndrome A antibody, Sjögren syndrome B antibody. These are also called as Rho antibody and La antibody. So if a patient with SLE develops these antibodies, that means he is going to develop the Sjögren's syndrome. His risk of developing Sjögren syndrome increases. Easy to remember because the name of the antibody itself is Sjögren syndrome A, Sjögren syndrome B. But presence of this SSA or anti-Rho also correlates with one more skin manifestation of SLE called as subacute cutaneous lupus erythematosus. Okay, and then most importantly, neonatal lupus. This is an important MCQ zone, right? Which of the following antibody correlates with the increased risk of neonatal lupus? Now, what do I mean by neonatal lupus? See, we know that the childbearing age, second and third decade, females are the people who are at risk of developing SLE. So, if the mother develops SLE and she conceives, right? If a pregnant woman who is having SLE, if she has this antibody called as anti-Rho or anti-SSA, then these antibodies are passively transferred to the baby, transplacental transfer. And the baby which receives these antibodies, right, develops what we call as neonatal lupus. The patient, the baby is not affected by SLE, but it starts showing some signs and symptoms of SLE because it has passively received the antibodies from the mother. The most important antibody is anti-Rho antibody. And what manifestations we would encounter in that neonate? The rash, the typical SLE like rash, and most importantly, heart block. Right, so this, according to me, this time is going to be a very important MCQ point. Which antibody correlates with the risk of neonatal lupus or correlates with the risk of heart blocks in the newborn to a baby born with mother being SLE positive. Okay. Then we have another antibody which is Sjögren syndrome B antibody, which only correlates with the risk of Sjögren syndrome. So I would be more than happy if I have a pregnant woman who has anti-SSB antibody, because yeah, she might develop Sjögren syndrome, but she does not have the risk of giving those antibodies to the newborn and the newborn developing the neonatal lupus or heart block. Okay. Then we have one antibody called as anti-ribosomal P antibody, which correlates with the risk of depression and psychosis. Many of the SLE patients go through major depression, psychosis, and they have suicidal tendency, and presence of this antibody correlates with it. Okay. Then we have this anti-neuronal antibody. Name says neuronal, easy to remember. It correlates with CNS lupus. So what happens in CNS lupus? They develop dementia. Just like how we develop dementia in Alzheimer's and Parkinson's and various other disorders, SLE patients also develop dementia. So if I have an SLE patient with anti-neuronal antibody, I know that he is at risk of developing dementia. Okay. The last antibody is particularly important, which is anti-U1-RNP antibody, which correlates with the risk of what we call as mixed connective tissue disorder. Now, what is this mixed connective tissue disorder? As the name says, mixed connective tissue disorder means you have not only one, not only SLE, you have other rheumatological disorders all co-occurring in one patient. Like Sjögren syndrome and SLE together in one patient, then we call it as overlap syndrome. Right? Such patients, when they have this antibody called as anti-U1-RNP antibody, we call it as mixed connective tissue disorder. This MCQ has been asked multiple times in the FMGE, which antibody correlates with MCTD risk, which is anti-U1-RNP antibody. Okay. Now, having done with the epidemiology, risk factors and antibodies, we will spend 5 more minutes on the clinical manifestations. Okay. When it comes to clinical manifestations, the first MCQ they would ask you is what is the most common constitutional symptom in a patient with SLE. Now, what is a constitutional symptom? Symptoms which are not attributable to a particular system. They are diffuse symptoms. For example, if I am experiencing fatigue, right, can you say this fatigue is because of cardiovascular dysfunction, it is because of musculoskeletal problem, it is because of joint problem, it is because of respiratory problem? All of them can manifest with fatigue, right? So fatigue will be counted as one of the constitutional symptoms. The most common constitutional symptom that we encounter in patients with SLE is going to be fever. This is a potential MCQ point. What is the most common constitutional symptom in patients with SLE? Many patients with SLE present to hospital as recurrent episodes of fever, and on evaluation we find out that okay, it is ANA positive, anti-dsDNA positive patient, and then we will label it as SLE. Okay. Then when it comes to skin, right, the most common manifestation is what we call as malar rash. I'm very sure all of you are aware of this malar rash, which has this characteristic distribution of butterfly distribution of the rash with the nasolabial fold sparing, right? There is sparing of the nasolabial fold, and rest of the malar region there is erythema, which is photosensitive. On exposure to sun, the rash appears. The rash may disappear or regress when there is no sun exposure. That's the most common cutaneous manifestation. Now, the most common musculoskeletal manifestation is going to be polyarthralgia or polyarthritis. Polyarthritis. So can anybody tell me what do I mean by polyarthritis? See, when there is inflammation of one joint, we call it as monoarthritis, right? But we have two more terms, polyarthritis, oligoarthritis. What do you mean by poly? When do you say it is poly? How many joints should be involved to call it as polyarthritis? Not exactly many, right? So please remember, I will just put a small note here. So when one joint is affected, we will call it as mono, right? 2 to 4, we call it as oligo. And when it is more than 4, that means 5 or more than 5, we will call it as poly. We will call it as poly. Okay. So patients with polyarthritis, can you give me one more example where you have polyarthritis? I will describe this polyarthritis. The polyarthritis that we see in SLE, right? The polyarthritis that we see in SLE is bilaterally symmetric. Bilaterally symmetric, it affects the upper limbs more than the lower limbs. It affects upper limbs more than the lower limbs. Okay. It affects small joints of the hands more than the large joints. Can you give me one more disorder where there is a similar distribution of joint involvement? Bilaterally symmetric, upper limbs more affected than the lower limbs, small joints of the hands more affected than the large joints, means elbow or shoulder joints. A classical example is rheumatoid arthritis, right? Rheumatoid arthritis is a classical example. Then what is the difference between the nature of joint involvement in SLE and the nature of joint involvement in the rheumatoid arthritis? What is the difference? Are they both same? Because both affect upper limb more than the lower limb, both affect small joints more than the large joints, both are bilaterally symmetrical, both are polyarthritis. The difference is, in rheumatoid arthritis, it is an erosive arthritis. Now, what do I mean by erosive arthritis? The joints will get eroded, and because of that, you develop true deformities. The eroded joints will become deformed. In SLE, because there is no joint erosion, there are no true deformities. So, that's the important point to note here, right? It is a non-erosive arthritis. Non-erosive arthritis, and hence, there will be no true deformities. In rheumatoid arthritis, we get these deformities, right? Like swan neck deformity, Z deformity. All those deformities are not seen in patients with SLE because they do not have joint destruction or erosion. But you can have fake deformities. We call them as pseudo deformities, or we also call it as Jacquard's arthropathy. Jacquard's arthropathy. What is this Jacquard's arthropathy? Here, you get deformities, but the pathology is not in the joints. The surrounding connective tissue, the tendons, right, ligaments, they become weak. So because of that, the joints assume a deformed position, but they are all reducible. Like you get this swan neck deformity in rheumatoid arthritis, you can't correct it. But a patient with Jacquard's arthropathy, the deformities are because of the weakness of the supporting connective tissue, the tendons and the ligaments. So you can easily correct it. It will go back, but you can correct it. It's a fake deformity that you can see in patients with SLE, but not true deformity. That's the difference between rheumatoid arthritis and SLE. Now, when it comes to cardiovascular manifestations, right? When it comes to cardiovascular manifestation, the most common cardiovascular manifestation of SLE is, remember, it is pericarditis. So in SLE, rheumatoid arthritis, and for that matter, almost all of your rheumatological disorders, the most commonly involved major organ manifestations are mainly the serositis. Now, what do I mean by serositis? Serosa refers to the membranes lining the vital organs, right? The pleurae, pericardium and peritoneum. They get inflamed. So, in CVS, it is pericarditis, right? In RS, it is pleuritis. So, the most common respiratory system manifestation of SLE is going to be pleuritis. The most common cardiovascular system manifestation is going to be pericarditis. But please remember, the SLE affects all the three layers of the heart. It will cause pericarditis, it will cause myocarditis, it can also cause endocarditis. So it affects all three layers. And if it causes endocarditis, what do we call it as? Affects all three layers. And if it is affecting the endocardium, we will call it as Liebman-Sachs endocarditis, right? We call it as Liebman-Sachs endocarditis, because this is an endocarditis where the endocardium is not inflamed because of infection. So otherwise we have this infectious endocarditis, right, where organisms like Staph epidermidis, Staphylococcus aureus have caused the infection to the endocardium. Here it is the interferon 1 and other inflammatory cytokines and antibodies have caused the damage and inflammation to the endocardium. So thus it is going to be a sterile endocarditis called as Liebman-Sachs endocarditis. Where do we see that? We see that in patients with SLE. Again, an important MCQ point. When it comes to CNS, the most common manifestation is the cognitive dysfunction. And when I say cognitive dysfunction, what does that mean? It means a mild form of dementia, right? So cognitive dysfunction or dementia is the most common CNS manifestation of SLE. When it comes to respiratory system, I have already told you pleura is the most commonly affected structure. But apart from that, the SLE also affects the lungs directly. What all it can cause to the lungs? To the lungs, it can cause what we call as diffuse alveolar hemorrhage. Diffuse alveolar hemorrhage or DAH. Diffuse alveolar hemorrhage, also abbreviated as DAH, where there will be bleeding into the alveoli because of the vasculitis, and such patients have high risk of mortality. It also causes interstitial lung disease. And when it causes interstitial lung disease, there are two types of interstitial lung disease. One of them is called as UIP pattern and the second one called as NSIP pattern. Typically here we see NSIP pattern. Okay. And then there is one more, which is an interesting point, and this is going to be an important MCQ point this time, which is called as shrinking lung syndrome. In one of the previous FMGE, I have asked where do you see shrinking lung syndrome, and that answer was pretty simple, SLE. This time they might give you a clinical story and then ask you to identify what is it, right? So we call this condition as shrinking lung syndrome. Why is it called so? What is it? So basically what happens in SLE, in patients with SLE, when they come with shortness of breath, right, the possibility is that they might have developed diffuse alveolar hemorrhage, they might have developed interstitial lung disease, or they might have developed shrinking lung syndrome. Okay. The diffuse alveolar hemorrhage, it presents as a case of ARDS. Very easy to identify. You have bilateral infiltrates on the chest X-ray, abnormal chest X-ray, easy to identify. Okay. ILD chest X-ray may not reveal, but at least HRCT will reveal, where you have the interstitium, the connective tissue, and the alveoli are getting fibrosed. Then you have this shrinking lung syndrome. What happens here is the lung volume gets reduced. So the size of the lungs shrinks. But the shrinking in the size of the lungs is not because of the pathology of the lungs. So lungs are absolutely fine. So when you look through the CT scan of the lungs appear normal, but their size is reduced. The lung capacity, the lung volumes are reduced because the size is reduced. Why the size is reduced? Probably because of the weakness of the diaphragm. Diaphragm is not able to descend down well, and probably because of the fibrosis of the chest wall. So chest wall is fibrosed, not able to expand well. Diaphragm is not able to descend well, and that is why the lung volume will be reduced. How do we identify it? Whenever they say that an SLE patient presented with shortness of breath, right, and there are no findings suggestive of interstitial lung disease or diffuse alveolar hemorrhage on the X-ray, and X-ray, lung fields appear normal. Lung fields appear normal, but the diaphragm is elevated. Why the diaphragm is elevated? Because it is not able to descend down, like you see in this X-ray, right? Especially here, right side, it is very prominent. You can see that the right diaphragm is quite higher. When I look through the lung parenchyma, it is very clear. There are no opacities, but the hemidiaphragm is elevated. So in an SLE patient, if you see this finding, it should point towards the possibility of what we call as shrinking lung syndrome. What has happened in shrinking lung syndrome? Lungs are fine, the surroundings, the chest wall is fibrosed, diaphragm is weak, right? So in shrinking lung syndrome, you have reduced lung volume, right? So decreased lung volume, normal lung parenchyma on the chest X-ray, and elevated diaphragm. So whenever you get this picture, you're talking about a patient with shrinking lung syndrome. Okay. Will SLE affect the hematological system? Yes. What is the most common manifestation? The most common manifestation is SLE being a chronic disorder. It will cause anemia of chronic disease, right? So what should be the peripheral smear picture? Normocytic, normochromic anemia. So the most common hematological manifestation is going to be normocytic, normochromic anemia, which is nothing but anemia of chronic disease. Okay. Now they will ask you one last question from clinical manifestation, that is, why do patients with SLE die? In the past, patients with SLE used to die because of what we call as lupus nephritis. Even now, it is an important cause for mortality, but with the advent of stronger immunosuppressant drugs, we are able to save majority of these patients from death. Then why do these patients still die? Obviously, SLE has a higher risk of mortality than any other normal individual. A classical example is a very famous politician's wife died quite in young age, and one of the theory was that she died because of SLE. What could be the most common cause of death? Most common cause of death is coronary artery disease. So in patients with SLE, there is inflammation of the blood vessels also, and the inflamed blood vessels have the tendency to clot, right? So coronary artery disease is the most common cause of death in SLE. The lupus nephritis is the second most common cause of death. It is no longer the most common cause of death. Okay. Now, how do we diagnose a patient with SLE? We apply a criteria called as ACR-EULAR criteria. Because the FMGE exam is very nearby, I am not getting into the details. Obviously, they will not ask you to memorize this criteria and come to the examination hall. So, I will give you the essence, what you need to remember. So, according to this criteria, you will start thinking that my patient may be having SLE only when it meets the entry criteria. Means the thought process कि हाँ ये हो सकता है शायद SLE का case should start only when this first entry criteria is met. What is that entry criteria? The ANA should be positive. ANA should be positive. ANA should be positive using the indirect immunofluorescence, and the titer should be more than 1:80 titer. More than 1:80 titer. Only then you will start thinking about SLE, right? And once the titer is positive, then you will apply the score. In the score, you get two parameters. One is laboratory criteria, which mainly looks at the antibodies that we discussed, right? The anti-dsDNA antibody and other lab parameters. And you have the clinical parameters, which we will discuss, the observation that we made, right? The hematological manifestation, renal manifestation, CNS manifestation, cardiovascular manifestation, and we will give score to individual points. How much score is required to make a diagnosis of SLE? We need more than or equal to 10, and out of which at least 1 point should be from clinical criteria. So if you are getting all the 10 points from only lab parameters, we can't call it as SLE, because I will give you examples of my own patients who meet all the lab criteria but they have no clinical signs of SLE. I cannot label such patient as having SLE. Only when they start developing clinical symptoms, we will count it as a case of SLE. So out of the 10 points that you are calculating, you are getting from the patient, at least 1 point should be coming from the clinical parameters. Okay. Now, once I have diagnosed the case as SLE, how will I manage? Obviously, management depends on the severity. In the exam, what they will ask you is what is one standard drug that you will give for all SLE patients until and unless there is a contraindication, like the first line medication, right? Or we also call it as blanket prescription, means that is for all patients. Just like any patient with fever, we give paracetamol, right? Whether it is because of malaria, whether it is because of dengue, whether it is because of HIV, right? Until and unless there is a contraindication to paracetamol तो देते ही, right? वैसे ही SLE के लिए भी एक ड्रग है जो अगर कॉन्ट्राइंडिकेशन नहीं है तो सारे SLE पेशेंट को देते हैं, रिगार्डलेस ऑफ माइल्ड है, मॉडरेट है या सीवियर है. So what is that drug? Bhavika Sarvade, absolutely right. We need a score of 10 or more than 10. Sahib Chakrabarti, absolutely right. There is accelerated atherosclerosis. Accelerated atherosclerosis is because the inflammatory cytokines that are produced, they cause endothelial injury. And we might have studied in something called as Virchow's triad, which says if there is endothelial injury, it is a risk factor for development of clot. So the tendency to clot is also high in SLE patients, and the rate of developing atherosclerosis is also high in SLE patients. Bharat, no. The methotrexate is a blanket prescription or the first line medication for patients with rheumatoid arthritis. For patients with SLE, it is going to be hydroxychloroquine. Hydroxychloroquine. So all patients with SLE should receive hydroxychloroquine until and unless there is a contraindication. And when I say until and unless a contraindication, that also means that we should know the contraindications, right? So what are the contraindications for the use of hydroxychloroquine? There are two major contraindications. One you study from ophthalmology and one from medicine, mainly cardiology. In fact, we lost I think 1 or 2 doctors during COVID because they took hydroxychloroquine. During COVID, there was the theory that if you take hydroxychloroquine, it reduces the risk of developing cytokine storm and thus reduces the mortality and prevents your risk of getting infected with COVID. So many doctors started in quite early phase of COVID. Later we realized that it doesn't protect, so we stopped. But during the early phases, when people started taking hydroxychloroquine, I think someone from Assam, he went to bed, he took hydroxychloroquine, he was on duty for COVID, he went to bed and next day morning he didn't wake up. Right, so one is the retinopathy. So contraindication is, yes, it causes bullseye retinopathy. So retinopathy is a contraindication. So if you already have an abnormal retina because of diabetes, hypertension or anything, hydroxychloroquine will cause more insult to the retina. So if an existing retinopathy, it is a contraindication. Even when I start hydroxychloroquine, regular screening for retinopathy is mandatory. Second, it causes QT interval prolongation. QT interval prolongation. And whenever there is prolonged QT interval, right, it increases the risk of developing one particular arrhythmia. Can anybody tell me which arrhythmia risk is increased if there is prolonged QT interval? I'll give you a clue. It's a particular type of polymorphic ventricular tachycardia. We call it as Torsades de Pointis, increased risk of Torsades de Pointis. Torsades de Pointis, which is nothing but a polymorphic ventricular tachycardia, where the ventricular tachycardia looks like a waveform or twisting around its axis. We call it as Torsades de Pointis, and that can be fatal if not recognized or treated. So we should keep that in mind. Hydroxychloroquine is one drug that we will give for all patients with SLE, whether it is mild, moderate or severe. But before we initiate, we should screen the retina for the retinopathy, and we should get an ECG done to make sure that there is no pre-existing QT prolongation. If already QT is prolonged, if I start hydroxychloroquine, further prolongation and the risk of Torsades de Pointis. Okay, so here is a table which is the latest guidelines for management of SLE. For an FMGE student, right now it is not important. All they will ask you is what you will start with. We will start with hydroxychloroquine, and if hydroxychloroquine is not helping, what options we have? Right? We will flat out bring steroids and immunosuppressants. What are the steroids? Basically glucocorticoids like prednisolone, methylprednisolone, and then when it comes to immunosuppressants, we will use methotrexate, azathioprine, mycophenolate mofetil. Those are the drugs. But in the recent times, we have come out with certain newer drugs for SLE, and that is the MCQ area for us. Bharat, absolutely right. So when someone develops Torsades de Pointis, if he is hemodynamically stable, the drug of choice is magnesium sulfate. A very, very important MCQ point. In fact, repeatedly asked question. They give you a history saying that someone presented with palpitation or was found in collapse state. ECG done, they will give you the ECG image where you get this wave-like polymorphic ventricular tachycardia. You will recognize by looking at the image that this is Torsades de Pointis, and they will ask you what is the drug of choice. It is magnesium sulfate. Okay, so there are two new drugs for the SLE. The first one is called as belimumab. What is this belimumab? They will ask you the mechanism of action. Belimumab is a monoclonal antibody against B lymphocyte stimulant, right? It is a monoclonal antibody against B lymphocyte stimulant. This B lymphocyte stimulant is abbreviated as either B-LIS or BAF. See, it's an antibody-mediated disorder we just learned, right? SLE. So many antibodies we studied: anti-dsDNA, anti-Smith, anti-Rho, anti-La, right? All of these are antibodies. Which cell produces antibody? It is primarily B lymphocytes, right? So if I reduce the B lymphocyte production itself, right, by inhibiting some cytokine which is stimulating the B lymphocytes in their replication, then I will reduce the antibody production. That is the principal thought process behind this drug called as belimumab. They can ask you the mechanism of action. And then this is the most latest drug that we have, which is called as anifrolumab. See, these drugs are very easy to remember. The name is belimumab, basically B lymphocyte stimulant blocker. Anifrolumab, what is its mechanism of action? What is the principal cytokine involved in the pathogenesis of SLE? It is interferon 1, right? So this is a monoclonal antibody against interferon. Anti-interferon monoclonal antibody, anifrolumab. So it's a monoclonal antibody against interferon 1. There was one MCQ in the previous NEET PG, I guess, or maybe INS-CT, where they were asking you which of the following is the first monoclonal antibody approved for treatment of SLE. That is belimumab, right? Which of the following is the first monoclonal antibody targeting interferon 1? That is going to be anifrolumab. Okay, so that's a quick review of SLE. A closely related topic is antiphospholipid syndrome. That is what you recognize as APLA, antiphospholipid antibody syndrome. Today, instead of calling it as APLA, we call it as APS, antiphospholipid syndrome. Okay, now what is this antiphospholipid syndrome? It is also an autoimmune disorder where patients have a tendency to develop unnecessary, unstimulated clots. Normally when we develop clots, when there is an injury, when we start bleeding, to contain bleeding, we develop a clot. But these patients have a tendency to develop clots without trauma. Why are they developing? Because of presence of certain antibodies. So we will summarize it as antibody-mediated thrombophilia syndrome. When you say thrombophilia, what does it mean? It means tendency to clot. It means increased tendency to develop clots. Antibody-mediated increased tendency to develop clot. So this is also an autoimmune disorders, and by default autoimmune disorders are more common in females than males. Okay. So typically where are we developing these clots? Most importantly, we are developing clots in the veins more than arteries. This point appears multiple times in MCQs asking you which of the following is a false statement about antiphospholipid syndrome, right? And one of the statement would be like arterial thrombosis is more common than venous thrombosis. That's false. Veins are the ones which are more likely to develop clots than the arteries. Okay. And then they will ask you what is the most common complication. The most common complication or most common manifestation of antiphospholipid syndrome is the deep vein thrombosis of lower limbs. Deep vein thrombosis of the lower limb veins. So most of these patients come to light when they develop a DVT, right? They come with a swollen limb, and when we do a Doppler, we find out that the deep veins of the calf vein has developed a clot. Okay. Then they will also ask you an MCQ, what is the most common arterial complication? DVT of the lower limb is a venous complication. That is the overall most common complication, overall most common venous complication. But what is the overall most common arterial complication? Overall most common arterial complication is stroke, and antiphospholipid antibody syndrome is one of the important risk factors for stroke in young individuals. Like ideally stroke happens after 45 years of age, but if someone develops stroke before 45 years of age, we call it a stroke in young, and APS is one of the causes. And then you have studied about antiphospholipid syndrome in OBG as well, because obstetric complications also happen. So that includes intrauterine death, right, as well as premature delivery. So in simple words, recurrent pregnancy loss. That is why whenever someone says that there were 2 abortions, 3 abortions in the past, we do investigate for the possibility of antiphospholipid syndrome. Okay. Now how do we diagnose? The diagnostic criteria is called as revised Sapporo criteria. The name is important MCQ point. What is the diagnostic criteria for the antiphospholipid syndrome? The name of the criteria is revised Sapporo criteria. So there are two criteria here. The first one is clinical. The second one is laboratory. What is laboratory? Basically looking for antibodies, which we will discuss. What are the clinical criteria? Clinical criteria is one of the clinical criteria should be present, and that includes at least one event of arterial or venous or a small vessel thrombosis affecting any organ, or obstetric parameter, that is death of one or more than one morphologically normal fetus after 10 weeks of gestation, or premature delivery of a morphologically normal fetus before 34 weeks of gestation, right? Or 3 or more than 3 consecutive spontaneous abortions before 10 weeks of gestation. Why emphasis on morphologically normal fetus? Because if fetus had morphological abnormalities like congenital defects, right, then those defects explain why there is intrauterine death or why there is premature labor. But if you had normal fetus but still there was intrauterine death or there was premature labor, it may point towards the presence of blocks or clots in the blood vessels feeding the fetus from the mother. Okay, what are the laboratory criteria? We have 3 antibodies. At least one of the antibodies should be present, and this is where they will ask you MCQs. What are those antibodies? Anti-cardiolipin antibodies, anti-beta-2 glycoprotein antibodies, and lupus anticoagulant. Usually this we abbreviate as lupus anticoagulant, right? Anti-cardiolipin antibody is abbreviated as ACL, and anti-beta-2 glycoprotein is usually abbreviated as anti-beta-2 GP antibody. At least one of these should be positive, and it should be positive in 2 samples taken at least 12 weeks apart, right? 12 weeks apart. Means if a single sample lupus anticoagulant is positive, it doesn't mean that the person has the antiphospholipid syndrome. I do it one sample now, 3 weeks later I do one more sample, both are positive, then only I will consider it as positive, right? 2 samples positive 2 weeks apart, then only it is relevant. Otherwise it is not relevant. The time frame is also important. Okay. So when we diagnose someone as having antiphospholipid syndrome, what do we know? That okay, these patients have antibodies. Because of these antibodies, they have a tendency to develop unstimulated clots. Clots typically develop in the veins more than arteries. Veins of the lower limbs are more affected, right? Apart from that, if it is a childbearing age female who is trying to conceive, this may lead to obstructive complications in the form of premature delivery or intrauterine death or abortions, right? So how do I prevent these risks of patient developing deep vein thrombosis? Because once someone develops deep vein thrombosis, there is a risk that it will embolize and cause pulmonary embolism and can contribute to death, right? And then obviously the female wants to conceive, and this antiphospholipid syndrome is becoming a roadblock. So how do I solve the problems, right? So if you diagnose someone having antiphospholipid syndrome and they are asymptomatic, then we treat them with aspirin alone. Aspirin alone means they have not developed any of the major organ manifestations as of now, then we will treat them with aspirin alone. But if they have developed even a single event of thrombosis, like okay, now he has a deep vein thrombosis, so 6 months back, 1 year back, 2 years back, he had a DVT, right? Even if there is a single event of thrombosis, we have to give them lifelong aspirin, but aspirin alone is not enough. Aspirin plus anticoagulant. And when I say anticoagulant, the question is what is the anticoagulant of choice? Anticoagulant of choice. See, you have so many anticoagulants, right? You have warfarin, you have direct acting oral anticoagulants like the apixaban, right? Zimmelgatran, dabigatran. Then you have heparin, low molecular heparin. What will be the anticoagulant of choice? The anticoagulant of choice is going to be warfarin. Anticoagulant of choice is going to be warfarin, right? And if warfarin is contraindicated, in such cases the second choice will be direct acting oral anticoagulants like dabigatran, zimmelgatran or apixaban. Okay. In pregnancy, can I use warfarin? In pregnancy, can I use warfarin? In pregnancy, yes, there is a risk of premature labor, intrauterine death and abortion. So obviously I need to treat, right? Pregnancy, I can comfortably give aspirin, no contraindication to aspirin during pregnancy, so definitely we will give aspirin, but I would require an anticoagulant. What should I use? The anticoagulant that we would use is the low molecular weight heparin, because warfarin is teratogenic, right? If you do not want to continue low molecular heparin throughout pregnancy, you can consider switching to warfarin in the second trimester, but most of the doctors are not comfortable doing that, so we continue to treat them with low molecular heparin throughout the pregnancy and aspirin throughout the pregnancy. That is about the antiphospholipid syndrome. Again, giving you a summary, what is it? It is an autoimmune disorder where antibodies increase your risk of developing clots. Clots most likely develop in the veins of the lower limb. Rarely they can also develop in the arteries. If they develop in the artery, they most likely cause stroke. If they develop in the veins, they cause DVT of the lower limb. And these clots can also develop in the umbilical vessels, and that is why they are associated with increased risk of obstetric negative outcome in the form of premature labor or abortions. Right. So if I have to diagnose it, I need some clinical parameters plus antibodies. The antibodies are anti-cardiolipin antibody, anti-beta-2 glycoprotein antibody, and lupus anticoagulant. Single sample positivity does not confirm the diagnosis of antiphospholipid antibody. At least 2 samples should be positive, which are taken 12 weeks apart. So one now, 3 months later, one more, both positive. Then only you make the diagnosis of antiphospholipid syndrome. Once you diagnose, if patient has no major organ manifestation, just give him aspirin. If there is history or ongoing, even a single episode of thrombosis, whether vein, artery, DVT, stroke, whatever, we have to give anticoagulant. Anticoagulant of choice for a long-term management is going to be warfarin, but warfarin is not safe in pregnancy, so we give them the low molecular weight heparin, right? So that completes our discussion of the antiphospholipid syndrome. We will go to the next topic, which is scleroderma. Okay. Now, when you look at the name of the disease, it says sclero and derma, right? What does that mean? Derma means skin. Sclero means sclerosis, refers to fibrosis, hardening or damage. So basically we are referring to hardening of the skin. So when we say scleroderma, indirectly it means hardening of the skin. Okay. Now there are 3 terminologies which we need to get ourselves acquainted with. The first one is morphia and the second one is systemic sclerosis. Under that we come across 2 terms. One is diffuse cutaneous systemic sclerosis and the other one is limited cutaneous systemic sclerosis. Limited cutaneous systemic sclerosis, right? Okay. And also please be aware that systemic sclerosis is equal to what we call as scleroderma. Both mean the same thing. If you say scleroderma, it means same. If you say systemic sclerosis, it means same. But first word, morphia, right? What morphia stands for? Morphia stands for thickening of the skin without organ involvement. Morphia means skin thickening without organ involvement. If there is skin thickening with organ involvement, then we will call it as scleroderma or systemic sclerosis. So if there is skin thickening with organ involvement, right? The name says systemic sclerosis. System means organs plus skin. So skin thickening plus organ involvement, then we will call it as systemic sclerosis. And because this is a condition where there is organ involvement, they will ask you which organ is most commonly affected, what is the most common manifestation in the involvement of that organ. So we will go there in a bit. But even when we make an assumption that okay, here is a patient where there is hardening or thickening of the skin, and along with that there is also fibrosis or involvement of the organs. Within that we have 2 types, the diffuse cutaneous type and the limited cutaneous type. So how do we differentiate between these 2? These 2 are differentiated based on the extent of skin involved, right? So in limited cutaneous, the involvement of the skin is restricted to portions distal to the elbow in the upper limb and distal to the knee joint in the lower limb. The skin hardening does not progress more proximally. When skin hardening exceeds this, right, means progresses more proximal than the elbow joint upper limb and knee joint lower limb, then we will call it as diffuse cutaneous, right? So here the skin thickening is restricted to portions distal to knee joint and distal to elbow joint, only distal portions here, right? Skin hardening starts here, progresses maximum here, don't go beyond that. If you see that skin in the arms, right, thigh region, abdomen or anywhere else is hard, it means that you have diffuse cutaneous form of the systemic sclerosis, right? So what is the differentiating point between diffuse and limited cutaneous? Both are subtypes of systemic sclerosis, means skin plus organ, but the extent of skin involvement differentiates between the two entities. Okay. Now it is also an autoimmune disorder, right? This is also an autoimmune disorder, and then obviously there comes the question, which is the principal cytokine involved. So when it comes to SLE, it was interferon 1, but when it comes to systemic sclerosis, it is the transforming growth factor beta. So this is a cytokine which stimulates the fibroblast, and when fibroblasts are activated, they cause the fibrosis of the tissue. That's why we have this skin thickening or hardening, because the skin is getting fibrosed. We also have fibrosis of the internal organ. That's why we call it a systemic sclerosis. Okay. So what are the clinical manifestations? First MCQ that they would ask you is, what is the most common clinical manifestation? The most common clinical manifestation of patients with systemic sclerosis is what we call as Raynaud's phenomenon. Now what is this Raynaud's phenomenon? Raynaud's phenomenon refers to extensive pallor of the hands on exposure to cold, along with the numbness and tingling sensations. Why does that happen? It probably happens because of severe vasoconstriction. Okay, it happens because of vasoconstriction. That is the most common manifestation. Okay. Apart from that, there are various changes that we see in the skin, right? Apart from Raynaud's phenomenon, the other common manifestations are skin thickening. Skin thickening. And the skin thickening usually affects face and hands first, right? Hands and face. So what all happens in the hand? When there is thickening of the skin, right? Usually the palmar aspect, skin becomes more thick than the dorsal aspect. And because of that, the fingers will get flexed, because the thickening is more on the palmar side than the dorsal aspect, and it gives rise to this kind of a picture. So this can be an image based question. A patient presented with pallor and pain and tingling sensation while putting his hand into or her hand into water or cold environment, and on examination this is a finding we see. What do we call this finding? We call it as fixed flexion deformity. So when you see here, right, you can notice that the fingers are shiny, the skin is shiny. Why? Because the skin has become fibrosed, stick, right? It has become stiff. And when skin becomes fibrosed and hard to stretch, right, it's stretched, and that's why you're seeing that shininess. And because the palmar side is more thicker than the dorsal side, the fingers are in a flexed state, and we cannot extend it. They are not able to extend it because the skin is thick more on this side than the other side. So we call this deformity as fixed flexion deformity, right? Another point you can note here is that when you look at the fingers, right, fingers do not look proper and slender. They look like the sausages, right? So we call these as sausage shaped digits. Sausage shaped digits. Okay. Other than that, what else skin changes we will know? There can be hypopigmentation around the hair follicles, giving rise to what we call this as salt and pepper skin. Here you can see, right, dot areas of pigmentation present, surrounding that the pigmentation is gone. We call it as salt and pepper appearance. Okay. Apart from that, some of these patients can develop calcification of the soft tissues, mainly the fingertips. We call this condition as calcinosis cutis. Like you see here, all these white specks, those are calcified soft tissue. We call it as calcinosis cutis. Skin is the one which is calcified plus the underlying soft tissue. The same finger X-ray, you can see all the calcification in the soft tissue. Okay. Then apart from that, because these patients have vascular injuries, they can develop ulcers of the fingers, right? We call them as ischemic ulcers, because the fingers are not getting blood supply, they are ischemic. Now the skin changes are not restricted to hand, as I have already told you, it also affects the face. So when you look at the face of patients with scleroderma, you will notice that because of the fibrosis and thickening of the skin, right, the skin of the face becomes tight. It becomes tight, so they will not be able to give proper expression when you ask them, right? So because of that lack of proper expressions, we call it as mask of faces. Mask like face, in other words, mask of faces, right? And then what else you notice? The lips have become thin, right? These patients develop a thin upper lip. This all because of the fibrosis of the skin. Okay. Now once all my skin becomes tight, right, thick and tight, will I be able to open my mouth wide like normally I do? No. I will be able to open only little bit, right? So we call this as microstomia, right? Narrow oral opening, microstomia. And then when you look at these people's nose, again because of the thickening of the skin, right? If I just stretch and make my skin thick, the nose start looking like the parrot beak, right? So often these patients have a parrot beak nose. Parrot beak nose. These are the points that they usually mention in the MCQs, like a patient, female, presented with heightened sensitivity to exposure to cold, development of pallor, at times cyanosis, and tingling sensations or even paresthesias on exposure to cold of her hands. And on examination, she was found to have small opening of the mouth, thin upper limb, parrot beaked nose. What condition do you think of, right? We are thinking of systemic sclerosis or scleroderma. Okay. Apart from that, when you look closely at her face, right, you see these tiny pink pecks, right? What are these? These are called as telangiectasia, right? When you look closely, they look like tortuous, cutaneous, dilated blood vessels. We call them as telangiectasia. So we can see telangiectasia also in patients with scleroderma. Okay, so when we have these clinical manifestations, we think that patient may be having scleroderma, right? Most important what? Think of Raynaud's phenomenon and thickening of the skin, mainly the hands and face. Any question talks about it, think of scleroderma, right? Such patients have the risk of organ involvement. And when we talk about organ involvement, lungs are particularly affected. And the involvement of lung can happen in two ways. One, these patients can develop interstitial lung disease. And second, they can develop pulmonary arterial hypertension. They can develop pulmonary arterial hypertension. The serious involvement will be in the form of coronary artery disease, and in the past, not today, in the past, many of the patients with scleroderma used to die because of what we call as scleroderma renal crisis. Scleroderma renal crisis. Scleroderma renal crisis is an important MCQ area. Okay. I will talk about it, but before that, we will understand a little bit about the lungs. Because today, most of the patients of scleroderma die because of the complications related to lungs. In the past, scleroderma renal crisis was the most common cause for death, right? So today, it is the respiratory complications are the most common cause for death, which includes interstitial lung disease and pulmonary arterial hypertension. If you ask me specifically which one, pulmonary arterial hypertension is more important than the interstitial lung disease. Okay. Now, before I discuss little more about these two subtypes, the diffuse cutaneous and limited cutaneous, let me tell you few points about the scleroderma renal crisis. Right? What is the scleroderma renal crisis? Because that's an MCQ topic. Scleroderma renal crisis is a condition of hypertensive emergency. Means this is a condition where patients have sudden rise in blood pressure. Because of that, see, whatever common things we study in cardiology, right? Sudden rise in blood pressure, what all complications it can lead to? Bleed, right? Stroke, intracranial hemorrhage, stroke, hypertensive encephalopathy, hypertensive retinopathy, renal shutdown, right? These are the common complications. So that is how these patients present. They present as hypertensive emergency. And this hypertensive emergency is due to increased production of renin. So basically, scleroderma renal crisis is a high renin hypertensive emergency. So in the past, many of these patients used to die. Used to try to treat their hypertension with beta blockers and all, and they do not respond well. But today, it's not very difficult for us to treat because this renin, angiotensin, aldosterone axis can be easily blocked, right, with drugs like AC inhibitors. So they ask you often what is the drug of choice. The drug of choice is going to be AC inhibitors or ARBs. Studies have shown that AC inhibitors are superior to ARBs. The point to note, AC inhibitors are superior to ARBs. That's the point I want you to note. So if AC inhibitors are contraindicated, then only think of ARBs, or if AC inhibitors are not readily available, then only think of ARBs. Okay. Now, we studied about two types, right? Diffuse cutaneous and limited cutaneous. They ask you MCQs comparing the two. Because the two, it's not like, okay, I have started with a patient as limited cutaneous where only there is involvement of skin thickening, right? Distal to elbow, distal to knee joint, and some organ involvement. It is not that this patient will progress to become diffuse cutaneous, right? Right from the beginning, either it will be a limited cutaneous variant or it will be a diffuse cutaneous variant. Means if it is a diffuse cutaneous, thickening would have started everywhere simultaneously. If it is limited cutaneous, thickening would have started only distal to elbow. A limited cutaneous does not become diffuse cutaneous, a diffuse cutaneous does not become limited cutaneous. And that is why these two are clearly distinct two separate subtypes, right? And this risk of interstitial lung disease is typically more in patients with diffuse cutaneous type. Diffuse cutaneous type. And this pulmonary arterial hypertension is associated with limited cutaneous type. So if I know from the beginning only which type it is, right, I can also predict which organs are likely to get affected, right? Then how would I predict? One, skin involvement, but second, antibodies. Antibodies will hold a very important role in differentiating between limited cutaneous and diffuse cutaneous. The prototype antibody of limited cutaneous is the anti-centromere antibody. Anti-centromere antibody. And the prototype antibody for the diffuse cutaneous is anti-DNA topoisomerase 1 antibody, which is also called as anti-SCL70 antibody. Easy to remember, hai? I will try to summarize it. When you say SCL, right? SCL word refers to scleroderma. So it is an anti-Scleroderma 70 antibody. How to remember? Because in the exam, obviously it will create a confusion. Limited cutaneous में कौन सा, diffuse cutaneous में कौन सा, right? So let me simplify it. Let me say this is a cell, right? Inside the cell there is a nucleus and outside there is a mitochondria. Okay. Now I have to find centromeres. मुझे कहाँ पे मिलेंगे centromeres? Where do I find centromeres? Will I find the centromeres in the cytoplasm or nucleus? Where do we find the centromeres? Centromeres are the center point of the chromosomes, right? तो मिलेंगे कहाँ पे? न्यूक्लियस में. मतलब सेंट्रोमियर्स का प्रेजेंस लिमिटेड है, सिर्फ न्यूक्लियस के अंदर लिमिटेड है, राइट? एंड दे आर आल्सो रेडिली विजिबल ओनली इन सर्टेन फेजेस ऑफ सेल डिवीजन, राइट? हमेशा दिखेंगे भी नहीं. सो सेंट्रोमियर्स हैव लिमिटेड प्रेजेंस इनसाइड द सेल. So that way you can remember that anti-centromere antibody is the typical antibody associated with limited cutaneous. Centromeres limited जगह पे मिलेंगे, इसलिए वो limited cutaneous से associated है, right? But if I have to find the DNA, right? Can anybody say that DNA is only seen inside the nucleus? Is that true? If someone says that DNA is only seen inside the nucleus? नहीं, right? We also get this circular DNA inside the mitochondria, right? तो मतलब क्या है? The DNA has a diffuse presence inside the cells. It is not restricted or limited to nucleus. So this anti-DNA topoisomerase antibody diffuse cutaneous से correlate करता है. क्यों? Because DNA diffusely present है सेल के अंदर, सिर्फ न्यूक्लियस में लिमिटेड नहीं है. सेंट्रोमियर न्यूक्लियस को लिमिटेड है, इसलिए वो सिर्फ लिमिटेड क्यूटेनियस से मिलता है. सो दैट वे यू कैन रिमेंबर इट. अपार्ट फ्रॉम दैट दे विल आस्क यू इफ आई हैव अ पेशेंट विद सिस्टमिक स्क्लेरोसिस एंड ये एंटी सेंट्रोमियर एंटीबॉडी पॉजिटिव है, तो ये कौन से ऑर्गन इन्वॉल्वमेंट का रिस्क ज़्यादा दिखाता है, राइट? दैट इज प्रीटी सिंपल. The limited cutaneous is associated with increased risk of pulmonary arterial hypertension, as I have already mentioned, right? Pulmonary arterial hypertension. And ILD का risk diffuse cutaneous में ज़्यादा होता है. So if I have anti-centromere antibody, it means there is increased risk of pulmonary arterial hypertension and reduced risk of developing interstitial lung disease and scleroderma renal crisis. अगर मेरे पास दिस एंटी डीएनए टोपोआइसोमरेज 1 एंटीबॉडी होता है, इट मींस देयर इज इंक्रीज रिस्क ऑफ डेवलपिंग इंटरस्टिशियल लंग डिसीज एंड reduced risk of pulmonary arterial hypertension. Clear? There is one more antibody to remember here, which is anti-RNA polymerase 3 antibody, which is associated with the increased risk of scleroderma renal crisis. हमने सिर्फ 3 मेजर मैनिफेस्टेशंस की बात की है, राइट? लंग्स में pulmonary arterial hypertension and the interstitial lung disease, kidney में scleroderma renal crisis. I forgot to mention one more. There's also involvement of GIT in patients with Scleroderma, and the GIT involvement is in the form of what we call as GAVE. GAVE stands for gastric antral vascular ectasia. Antral vascular ectasia एक blood vessel abnormality है that we encounter in patients with SLE, patients with Scleroderma, which is also called as watermelon stomach. Watermelon stomach, because when you look through the endoscope, the stomach looks like the watermelon. Okay. Now here is a small table that will compare the limited cutaneous and diffuse cutaneous. From the Scleroderma, this is the most important topic. Okay. So there are 6-7 parameters to compare. I will make it easy for us to remember. Whenever you think of limited cutaneous, right, think of blood vessel, right? So consider limited cutaneous as primarily a blood vessel pathology. Blood vessel pathology. And whenever you think of diffuse cutaneous, right, think of organ pathology. All we need to do is only keep these two things in mind, and the rest of the table will emerge clear itself. Blood vessel, limited cutaneous का मतलब think of blood vessel, diffuse cutaneous का मतलब think of organ fibrosis or organ pathology, right? So first thing is the skin involvement, which we have already studied, right? So when you say limited cutaneous, that means the skin involvement is restricted distal to elbow joint in the upper limb and knee joint in the lower limb. And when you say diffuse cutaneous, the skin involvement extends proximal to elbow and knee joint. Okay. Now coming to Raynaud's phenomenon. Raynaud's phenomenon is a standard thing. It will be seen in limited cutaneous as well as diffuse cutaneous. Okay. But the involvement of joint, I have already told you, limited mein hamesha think of the blood vessels, right? And when it comes to diffuse, think of other organs involved. So joint involvement is more common and more severe with the diffuse cutaneous. That is why we see arthritis and tendinitis. We will only see mild joint pain, not obvious arthritis in patients with limited cutaneous, right? ILD organ के मतलब क्या think करना है? Diffuse cutaneous. ILD कब होगा? Diffuse cutaneous में. ILD is unlikely to happen or less likely to happen in a patient with limited cutaneous. Okay. Pulmonary arterial hypertension. Organ की बात हो रही है, blood vessel की. Pulmonary arterial hypertension. Are we talking about organ or blood vessel? Obviously we are talking about blood vessel, right? Pulmonary artery का pressure बढ़ गया है, so we are talking about blood vessel. So whenever we think of blood vessel, we should think of limited cutaneous, right? We should think of limited cutaneous. So pulmonary arterial hypertension is typically common in limited cutaneous, relatively rare in patients with diffuse cutaneous. Okay. Now when I say Scleroderma renal crisis, are we talking about an organ or a blood vessel? We are talking about an organ, right? So that is more common in the diffuse cutaneous, relatively rare in the patients with limited cutaneous. Okay, the last point, calcinosis cutis. I had shown you an image where there is calcification of the skin, right, called as calcinosis cutis. That is typically more common in the limited cutaneous. Calcinosis cutis is more common in the limited cutaneous. And because calcinosis cutis is more common in limited cutaneous, there is a syndrome called as CREST Syndrome, which is considered as a subtype of limited cutaneous systemic sclerosis. Limited cutaneous systemic sclerosis, right? What they will ask you is which of the following is, or which of the following is not a component of limited cutaneous systemic, not a component of the CREST syndrome. So let me write down the components of the CREST syndrome before we go to the management. Okay. So C here refers to calcinosis cutis, right? R here refers to what we know as Raynaud's phenomenon. Raynaud's phenomenon. E here refers to esophageal dysmotility. Esophageal dysmotility. So these patients can develop dysphagia, right? S here refers to sclerodactyly. Sclerodactyly. What does that mean? Your skin of the fingers is becoming sclerosed or fibrosed. So because of that, the fingers are shrinking in size, right? And then T here refers to telangiectasia. T refers to telangiectasia. Raynaud's phenomenon is a phenomenon where on exposure to cold or putting hands in cold water, there will be intense vasoconstriction resulting in severe pallor, maybe cyanosis, and pain and tingling sensations or paresthesias. We call it as Raynaud's phenomenon, which is the most common clinical manifestations of patients with scleroderma, followed by the thickening of the skin. Right? So CREST syndrome has these 5 components: calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly or sausage-shaped fingers, and telangiectasia. Clear? Okay. Now, when it comes to management of the scleroderma, we don't have, unfortunately, any effective treatment, because the main cytokine involved in its pathogenesis is transforming growth factor beta. Unfortunately, we don't have drugs to target it. There are drugs in development, but none of them have stood the test of time or completed the clinical trial successfully to come to the market. So how do we treat a patient with scleroderma? Mainly supportive. Means treat the symptoms that these patients are experiencing, right? So symptomatic treatment is the mainstay of treatment. And when it comes to symptomatic treatment, they will ask you 2 questions, right? What is the drug of choice for symptomatic treatment of Raynaud's phenomenon? And the second one they will ask you is what is the drug of choice for the scleroderma renal crisis? Drug of choice for scleroderma renal crisis. Okay, so can anybody tell me what could be the drug of choice for the Raynaud's phenomenon? Drug of choice for the Raynaud's phenomenon. Right. Problem क्या है? Intense vasoconstriction. So if I give vasodilators, the Raynaud's phenomenon would come down, right? So what all vasodilators do you know? So the calcium channel blockers will be considered as the drug of choice, and there are 2 types of calcium channel blockers: dihydropyridine calcium channel blockers and non-dihydropyridine calcium channel blockers. कौन सा प्रेफर करेंगे? Dihydropyridine calcium channel blockers. Dihydropyridine calcium channel blockers. To give you an example, amlodipine, right? Amlodipine. Easy to remember है, means the name of the drug itself has dipine, dihydropyridine. जो other calcium channel blockers, non-dihydropyridine calcium channel blockers are like verapamil, diltiazem, right? नाम अलग है. जो भी dipine में end होता है, they are all dihydropyridine type of calcium channel blockers like amlodipine, nifedipine, nicardipine, right? All of them are dihydropyridine calcium channel blockers. They are good vasodilators, and that is used as a drug of choice for Raynaud's phenomenon. Scleroderma renal crisis के लिए we have already spoken. That is going to be ACE inhibitors. They are the drug of choice for the scleroderma renal crisis. Okay. So that brings us to the next topic, which is Sjögren syndrome. Okay. To give you a summary of what is Sjögren syndrome, ये भी एक autoimmune disorder है, इसलिए हम rheumatology के अंदर बात कर रहे हैं. And when we say autoimmune disorders, वो या तो joints को target कर रहे हैं या तो कोई specific organ set को target कर रहे हैं. वैसे ही Sjögren syndrome is a disorder where autoimmune process targets the exocrine glands. Exocrine glands. See, we have 2 types of glands in the body: endocrine and exocrine glands. Endocrine glands के लिए हमारे पास n number of examples हैं autoimmune disorder. For example, can you name an autoimmune disorder which affects the thyroid gland? Thyroid is an endocrine gland, right? Examples are Hashimoto's thyroiditis, that is an autoimmune disorder, right? Then you have this Graves' disease, that is also an autoimmune disorder, right? Autoimmune disorder affecting the pancreatic endocrine component. Type 1 diabetes mellitus क्या है? It's an autoimmune disorder only, right? Antibodies against the pancreatic beta cells. So they are all autoimmune endocrine disorders. Sjögren syndrome is a disorder where exocrine disorders are targeted by the autoantibodies. Okay. So then comes the question: what are the most commonly affected glands? Bodhi and Sarkar, I have asked for a schedule. I think within 1 or 2 days they will schedule it. What are the most commonly affected glands? It is the lacrimal glands and the salivary glands. Lacrimal and salivary glands are the most commonly affected exocrine glands. So if I have the involvement of lacrimal glands, right? Lacrimal glands का main function क्या है? Production of tears. So the tear production रुक जाएगा. If I have the involvement of salivary glands, saliva production will be reduced. So these patients will typically come to the hospital saying that my eyes feel dry, Alright, my mouth feels dry, I have difficulty in chewing and eating food, I have difficulty because of my dry eyes, right? I feel a gritty sensation. That is going to be the usual presenting complaint. Okay, but before we reach here, right, already हमने बात की है Sjögren syndrome के बारे में when we were talking about SLE. When we were talking about SLE, we came across these two antibodies called as anti-Sjögren syndrome A antibody or anti-Rho antibody and anti-Sjögren syndrome B antibody or anti-La antibody. और वहाँ पे we studied that presence of this antibody in a patient with SLE is associated with increased risk of developing Sjögren syndrome. उसके अलावा it is also associated with increased risk of developing neonatal lupus, right? Associated with increased risk of neonatal lupus. अब इसका मतलब क्या हुआ? Sjögren syndrome can occur as an autoimmune disorder by itself, or it can also happen in patients having other autoimmune disorders just like SLE, right? ये rheumatoid arthritis में भी हो सकता है, right? Various other autoimmune disorders में भी हो सकता है. So that is why a patient with Sjögren syndrome will be said to have either primary, when it happens without any other autoimmune disorders, we will call it as primary Sjögren syndrome. लेकिन अगर ये किसी और autoimmune disorder के साथ में होता है, then we will call it as secondary. फिर क्वेश्चन आएगा, what is the most common cause for secondary Sjögren syndrome? SLE नहीं है, the most common cause for secondary Sjögren syndrome is rheumatoid arthritis. Rheumatoid arthritis, right? The other causes include SLE and mixed connective tissue disorder. ये other causes हैं. Most common secondary के लिए cause क्या है? Rheumatoid arthritis. That is going to be an MCQ for us. Okay. Now in Sjögren syndrome ये antibodies हमारे exocrine glands को damage कर रहे हैं. But which antibodies? We have already studied, right? There are two antibodies. The first one is anti-SSA, which is also called as anti-Rho antibody. The second one is anti-SSB, which is also called as anti-La antibody, right? Anti-Rho antibody and anti-La antibody. Apart from that, these patients can also have ANA. इसलिए SLA के साथ relationship है. So when I have these antibodies along with the CD4 T lymphocytes will cause the damage to exocrine glands. So once these exocrine glands get affected, what symptoms I will present with, right? Lacrimal gland involvement will lead to what we call as keratoconjunctivitis sicca. Keratoconjunctivitis sicca. That is why Sjögren syndrome is also called as sicca syndrome, right? What does that mean? There is inflammation of the conjunctiva and the cornea because of the dryness, right? Now how do I identify? These patients present with dryness of the eyes, and another symptom that these patients would often report is gritty sensation of eyes. So whenever a question says that a patient presented with dry eyes or gritty sensation of eyes, in the back of your mind you should start thinking about the systemic Sjögren syndrome, right, or the sicca syndrome. Now how do I confirm that these patients' eyes are really dry? There are two methods. One is called as Schirmer's eye test, which is a potential image based question. I'm sure you have also studied in ophthalmology. The other one is called as tear breakup time. Okay, so what do we do in Schirmer's eye test? We take a litmus paper, right, keep it in the lower palpebrae, okay, and then we will wait for 5 minutes. In 5 minutes, how much of this litmus paper becomes wet is what we check. Okay, so if the sufficient tear production is there, right, then the wetness will extend for more than 10 millimeter. 10 millimeter means 1 centimeter. So when you look at the litmus paper, it would be wet for a distance more than 1 centimeter from the point of insertion. If it is less than 1 centimeter, that means there is probably reduced tear production. And to confidently say that patient has got the keratoconjunctivitis sicca, there should be less than 5 millimeter wetness or less than half centimeter wetness of the litmus paper. Normal is more than 10 millimeter, right? This interpretation is easy to remember. 5 मिनट के बाद रीड करेंगे, अगर 5 मिलीमीटर से कम वेट हुआ है तो abnormal है, you have keratoconjunctivitis sicca. Alternate क्या करते हैं? Tear breakup time, वो अगर 10 सेकेंड से कम है तो that also indicates that patient has got keratoconjunctivitis sicca or cases. That is about the ocular manifestation of Sjögren syndrome. अब salivary glands भी target हो रहे हैं because of the Sjögren syndrome, right? So in the salivary glands, what it will lead to, right? So it is affecting the salivary glands. So what is happening in salivary glands? In the salivary gland, there is infiltration of the salivary glands by CD4 positive T lymphocytes. अगर ग्लैंड में बहुत से T lymphocytes घुस जाएंगे तो ग्लैंड का साइज क्या हो जाएगा, बढ़ जाएगा, राइट? So this will lead to one, decreased saliva production, and second it will lead to is salivary gland enlargement, right? Salivary gland enlargement, because बहुत से lymphocytes salivary gland के अंदर घुस चुके हैं, so that will lead to salivary gland enlargement. And if there is decreased salivary production, what will be the symptom? The patient will present with dry mouth or difficulty in chewing food. Dry mouth or difficulty in chewing food. Now for diagnosis के लिए ना हमको generally ये salivary gland की biopsy चाहिए. They will ask which salivary gland site you will choose for the biopsy. Is it the parotid gland, right? Sublingual gland, कौन सा site choose करेंगे, right? So site for biopsy, right? The site for biopsy is going to be labial. You will try to get the lip, right? Lip salivary glands, you will be able to see the CD4 T lymphocytes infiltrating the gland, like you see all these blue cells that you are seeing here. They are all lymphocytes, right? Literally infiltrating the salivary gland. So in any MCQ where they say that someone presented with dry eyes, dry mouth, and we took the labial biopsy which shows that the salivary glands are infiltrated by CD4 positive T lymphocytes, it is talking about the Sjögren syndrome. But Sjögren syndrome not only affects the ocular and salivary glands, it also affects other, means there are extraglandular manifestations. There is a table in the Harrison which mentions all the extraglandular manifestations. Exam के लिए table memorize करने की ज़रूरत नहीं है. There are 3 potential MCQs that can be asked from this table. The first one they will ask you is what is the most common extraglandular manifestation. मतलब gland के अलावा बाहर कौन सा most common manifestation है. So when you look at the table, the numbers speak for itself. 60% patients with Sjögren syndrome develop arthralgia or arthritis. So that's the most common extraglandular manifestation. Arthralgia or arthritis is the most common extraglandular manifestation. They might ask you what is the second most common extraglandular manifestation, and that is Raynaud's phenomenon. So we have already spoken about Raynaud's phenomenon in Scleroderma. Sjögren syndrome के patients भी can develop Raynaud's phenomenon. So the second most common is Raynaud's phenomenon. Raynaud's phenomenon. Okay. Then they will ask you what is the most common cardiovascular manifestation of the Sjögren syndrome, right? So look at the table and tell me what is the most common cardiovascular manifestation of the Raynaud's phenomenon, manifestation of the Sjögren syndrome. See, please remember when you say cardiovascular, we are referring to cardia and the blood vessels. Raynaud's phenomenon क्या है? Raynaud's phenomenon क्या है? Raynaud's phenomenon is a pathology of the blood vessels, right? Intense unnecessary vasoconstriction on exposure to cold. तो बात blood vessel की हो रही है. So which system it comes under? It comes under cardiovascular, right? So most common cardiovascular manifestation is also going to be Raynaud's phenomenon. So these are the 3 MCQs that they can ask you regarding the extraglandular manifestation of Sjögren syndrome. To give you a summary again, what is Sjögren syndrome? It is an autoimmune disorder where antibodies like anti-Rho or anti-La or anti-SSA or anti-SSB target your exocrine glands. Along with antibodies, CD4 positive T lymphocytes are also targeted. Most commonly affected glands are the tear glands and the salivary glands. Right? Because of that, dryness of the eyes, dryness of the mouth and enlargement of the salivary gland. For diagnosis, अगर biopsy लेने की ज़रूरत है तो labial biopsy is the site to be chosen. Okay. Now, how do we make a diagnosis? We follow ACR Euler criteria, just like how we have the same criteria for SLE, right? According to this, when we get a score of 4 or more than 4 on this table, we will classify the case as having Sjögren syndrome. Now, what goes into this table? The labial, as I have already mentioned, the site of biopsy is labial, right? Labial salivary gland with lymphocytic sialadenitis. Sialadenitis means salivary gland inflammation by lymphocytes. Okay, that's the first point. So, means labial biopsy showing labial salivary glands infiltrated by lymphocytes. Second, antibody. कौन से antibody को हम preference दे रहे हैं? Anti-SSA or anti-Rho. Please remember this is an MCQ because we studied about two antibodies, anti-Rho and anti-La. Right? Anti-La has no importance when it comes to diagnosis. होता है positive लेकिन diagnosis के लिए use नहीं आता है. The one that we use for the diagnosis is anti-SSA or anti-Rho antibody. ये directly MCQ आ सकता है, which of the antibody is part of the diagnostic criteria for Sjögren syndrome. It is anti-SSA, anti-Sjögren syndrome A or anti-Rho antibody, right? Then for the ocular involvement, you can do either Bischerwell score or you can do the Schirmer test. Interpretation of Schirmer test is what is important for us more than the Bischerwell score. The Schirmer test I have already told you. 5 मिनट में रीड करेंगे, अगर 5 मिलीमीटर से कम वेट हुआ है लिटमस पेपर तो abnormality है, right? And then you can also look at the saliva flow rate, right? अगर salivary gland ठीक काम कर रहा है तो flow rate अच्छा रहेगा, flow rate कम है तो problem है. So on this, when you get a score of more than or equal to 4, you classify the case as Sjögren's syndrome, right? Once you classify the case as Sjögren syndrome, how do you manage, right? Management is again symptomatic. कोई specific medication नहीं है. If there are dry eyes, we give artificial tears, right? Dry mouth, we use drugs and candies to stimulate the salivary production. There is no specific treatment for the Sjögren syndrome. Okay. Now, before I sign off today, one important table. I am expecting one MCQ from this, so I would suggest that all of you try to memorize if you are giving the FMGE exam. Because Sjögren syndrome के ऊपर clinical based questions already आ चुके हैं, जैसे कि हाँ patient presented with dry eyes, dry mouth, which antibody is likely to be positive. Those kind of questions they have asked, but dry eyes, dry mouth have a wide list of differential diagnosis. So next level of questions क्या होगा? How do we differentiate between a patient presenting with dry eyes, dry mouth? Right? So differential diagnosis क्या है? HIV associated Sicca syndrome, Sjögren's तो है ही, and then sarcoidosis. Okay, see, Scleroderma renal crisis is a high renin hypertension. Unfortunately, if it happens during pregnancy, we cannot use especially in the first trimester, we cannot use the ACE inhibitors or the ARBs because the safety is not proven. So we will treat the case as any other case of pregnancy-induced hypertension, right? So you can use the beta blockers. Obviously, you will require a very high dose of beta blockers and you might require the renal support. Beyond first trimester, you can consider using the ACE inhibitors. Okay. So these are the three important differential diagnoses. Sarcoidosis, Sjögren's and HIV. तीनों में dry eyes, dry mouth हो सकता है, right? So HIV is typically a disease which affects youngs, and we all know that HIV is more common in males, right? HIV, like when you look at the gender ratio, it is like 60% males and 40% are females. So typically HIV with the dry eyes and dry mouth is more likely to be a young male. On the other hand, Sjögren syndrome being an autoimmune disorder having close association with rheumatoid arthritis and SLE, which are again more common in females. Sjögren syndrome as such is more common in middle-aged females. When it comes to sarcoidosis, not much of gender preference. Sarcoidosis affects males and females almost equally. Okay. Then when it comes to antibodies, right? Will I have this antibodies in a patient with HIV? No, right? HIV virus itself is directly responsible for the failure of your tear glands and salivary glands. But in Sjögren syndrome, we have this anti-Rho antibodies. In sarcoidosis, again, we do not have antibodies. Right. When we do the biopsy of the affected salivary glands, in HIV, we know that CD4 cell count is low, right? So if the cells are invading the glands, obviously it has to be CD8 because CD4 counts are very low. So you will see that CD8 positive T lymphocytes are invading the glands. But in case of Sjögren's, it is the CD4 T lymphocytes. But in sarcoidosis, what do we see? In sarcoidosis, the affected glands have granulomas, right? We know that sarcoidosis and tuberculosis are somewhat similar, because in sarcoidosis and tuberculosis you have granulomas. The only difference is in tuberculosis you have caseating granulomas, in sarcoidosis you have non-caseating granulomas. Non-caseating granulomas. Otherwise sarcoidosis भी वही organs affect करती है जो tuberculosis affect करती है. Most common affected organ in sarcoidosis is lungs. Most commonly affected organ in sarcoidosis is in tuberculosis is lungs. Second most commonly affected organ in sarcoidosis is skin, similar in tuberculosis, right? Okay. Now genetics is the point to note here. When it comes to genetics, right? HLA-DR5 increases the risk of developing HIV-associated Zika syndrome. Then HLA-DR3 particularly increases the risk of developing the Sjögrens. Please remember, when we spoke about SLE also I told you SLE, DR2, DR3, right? DR4 is protective. So DR3 not only increase the risk of SLE but also increase the risk of developing Sjögren's syndrome. Similarly, the same DR3 increase the risk of developing sarcoidosis, right? So that's the quick summary of the rheumatology. What we have missed from the rheumatology discussion is rheumatoid arthritis, which will be covered in orthopedics, and vasculitic syndromes or vasculitis, where the large, small and medium vessel classification and some basic points which will be sufficiently addressed in pathology. You don't need to waste your time on the vasculitis topic from medicine. Whatever you study from pathology is more than enough for the FMGE exam, and whatever you study about rheumatoid arthritis from the orthopedics is more than enough. Okay, so before you sign off, let me tell you that I will be adding few MCQs in the notes which will help you to just assimilate whatever we discussed today. Until your exam, just focus on the points and the tables that we have discussed. More than this is not very important for the upcoming FMG exam. I made a brief summary of the important topics, so make sure that you are well versed with this. Like when it comes to SLE, antibodies and their correlation, right? Most common कौन सा है, most specific कौन सा है, most sensitive कौन सा है, drug induced में कौन सा आता है, which is associated with interstitial lung disease, which correlates with lupus nephritis, those kind of questions, right? Then organ involvement में most common, lungs में most common क्या है, cardiovascular system में most common क्या है, hematology में most common क्या है, that is one. And management में mostly the newer drugs which we have addressed. Antiphospholipid syndrome में the revised Sapporo criteria आपको by heart करना होगा. Management में कब aspirin और कब anticoagulants plus aspirin यूज करना है, that's what you need to remember. Scleroderma या systemic sclerosis में I have given you a table which compares the difference between limited cutaneous and diffuse cutaneous, and that is what you need to remember. Remember करने के लिए I have made it very simple. All you need to remember is limited में हमेशा think about blood vessels, problem blood vessels में है. When you think of diffuse cutaneous, think about the organ, right? So now tell me, Scleroderma renal crisis is more common in diffuse cutaneous या limited? ILD is more common in diffuse cutaneous or limited? जब भी organ की बात होगी, think of diffuse cutaneous. Interstitial lung disease, renal crisis, they are all in diffuse cutaneous, right? जब भी blood vessel आएगा दिमाग में, right? Think of limited cutaneous, like pulmonary arterial hypertension. That is limited cutaneous, right? Then some image-based questions are possible, mainly the Moscow facies, parrot beaking of the nose, right? Thin lips, tightening of the skin, fixed flexion deformities, sausage digits, calcinosis cutis, salt and pepper skin. So please go through those images, right? Scleroderma renal crisis, mostly the drug of choice they might ask you, or they might give you a clinical scenario. Like here is a patient who had Raynaud's phenomenon, thickening of the skin of the hands, and now patient is presented with blood pressure of 200, 120, reduced urine output, high creatinine, right? And what is the diagnosis, or how do you manage, or which antibody may correlate with this condition, right? What is the diagnosis? Renal crisis. How do we manage? AC inhibitors. Which antibody correlates with it? Because it is seen in diffuse cutaneous, the antibody is the one that is diffusely present. Yes, anti-DNA topoisomerase antibody. Remember, DNA is diffusely present inside the cell. Centromeres have limited presence inside the nucleus. Okay. CREST syndrome आपको components पूछेंगे. What are the components of the CREST syndrome? Yes, when it comes to telangiectasia, nothing but tortuous, dilated, small blood vessels. Again, blood vessels mean think of limited cutaneous, right? So CREST syndrome is a subtype of limited cutaneous. They will ask you the components of the CREST syndrome. What are those? C stands for calcinosis cutis, R stands for Raynaud's phenomenon, E for esophageal dysmotility, S for sclerodactyly or sausage-shaped finger, T for telangiectasia. शॉगरेन सिंड्रोम में आपको शिर्मर्स टेस्ट का इमेज बेस्ड क्वेश्चन आ सकता है, राइट। बायोप्सी फाइंडिंग मेनली CD4 या CD8 कौन सा सेल इन्वेड करता है, साइट ऑफ बायोप्सी कौन सा है, एंड एंटीबॉडी कौन सा डायग्नोसिस के लिए इंपॉर्टेंट है। डायग्नोसिस के लिए इट इज़ दी SSA और एंटी रो एंटीबॉडी, एंटीला डायग्नोसिस के लिए इंपॉर्टेंट नहीं है, राइट। सो आई विल गिव यू अ स्मॉल नोट ऑन बेसेट सिंड्रोम एंड इम्यून मीडिएटेड इन्फ्लेमेटरी myopathies on your notes. You can take a quick glance at that and that should be more than enough. This video will always be available on the YouTube. It will not be taken down, right? So there will be around 7-8 MCQs for you to take a quick glance and hopefully that should help you to sail past 50% questions coming from the rheumatology. Tomorrow we will be taking up the nephrology. Primarily focus will be on glomerular disorders, acute kidney injury, CKD, and some casts and some image-based questions. So if you just quickly glance to your notes and come, it will become much more easier. Okay, the notes will be shared on the PW Meta Telegram. You can download, and also it will be available on my Insta. Right. So I'll see you tomorrow at the same time, 5 p.m., 5 to 7, and as usual, our Read Harrison series will continue at 8 p.m. Okay. See you guys. Study focused. Stay focused. Don't try to do an exhaustive study now, right? जो एग्जाम में आएगा बस रटना है, एग्जाम तक बस जो भी कुछ मिसिंग है, अगर टाइम है उसके लिए तो रटना है। अगर आपने बहुत अच्छी तरह से ऑलरेडी पढ़ ली है तो जस्ट स्टिक टू योर सोर्सेज। आई वुडंट से दैट कि हाँ मेरे क्लासेस के नोट्स पढ़ो, नो। इफ़ यू ऑलरेडी ए सोर्स, यू हैव डन 1 or 2 रिविजन्स, स्टिक टू इट। ये सेशन हम उनके लिए कर रहे हैं जो मेडिसिन को मिस आउट कर चुके हैं और वट एवर दे हैव रेड इज ऑल एवापोरेटेड, तो उनके लिए एग्जाम से बिफोर में we are just trying to give them a push so that 50% के पार उनके नहीं आ जा सके, right? So I'll see you tomorrow again at 5 p.m. Till then, have a good time, guys. See you. Bye.